Welcome to today's deep dive. When you send over this massive stack of medical literature, we're talking oncology reports, clinical guidelines, pelvic health research, you're really looking for clarity on a highly specific medical mystery.
Yeah, and it's a mystery that honestly leaves a lot of people feeling completely isolated.
Exactly.
Okay.
Because usually when we talk about a diagnosis, there's this expectation of absolute precision. You break your arm, an x-ray shows the jagged white line, and the doctor points directly to it.
Right, it's binary, broken or not broken. We crave that visibility in medicine because categorization provides a clear, actionable roadmap for treatment.
But stepping into the world of pelvic health, particularly gynecological recovery, that x-ray machine just kind of shatters. We're looking at a diagnostic landscape that is incredibly murky.
Oh, it is the definition of diagnostic muddy waters.
Yeah, and so we're taking a deep dive into the very misunderstood question you asked. Can vaginal stenosis be mistaken for tightness rather than laxity?
Which is such a brilliant question. Because this specific issue affects millions, yet it remains buried under layers of cultural baggage and, frankly, medical silence.
Totally. So our mission today is to untangle the actual mechanics of pelvic health. We need to strip away the confusing terminology surrounding vaginal tightness versus laxity and really shine a massive spotlight on vaginal stenosis.
Because stenosis is a structural condition that people are suffering through entirely in the dark.
Right. And to start, we have to talk about how society, fueled by some pretty aggressive cosmetic marketing, consistently frames vaginal tightness as the ultimate positive baseline.
Oh, absolutely. It's sold as this metric of youth or vitality. And on the flip side, laxity is branded as a failure, like a problem to be fixed.
But the medical reality detailed in your sources shatters that narrative completely. Extreme tightness can actually be a glaring red flag for severe scarring, trauma, or profound hormonal depletion.
Let's unpack the baseline first, though. Looking at the anatomical literature, vaginal laxity is fundamentally a loss of structural support.
Right, because the vaginal walls are held up by this complex network of muscles, primarily the levator ani.
And they're woven together with connective tissues rich in collagen and elastin. Laxity occurs when that specific scaffolding is compromised.
And the sources point to two primary catalysts for that structural compromise:
Right.
natural aging and vaginal childbirth.
Exactly. Aging inherently decreases our natural collagen production, but childbirth exerts an extreme mechanical force.
I mean, the levator ani muscles undergo profound stretching and frequently micro-tearing just to allow a baby to pass through the pelvic floor.
The research indicates 50% of women post-vaginal birth experience some degree of vaginal laxity. 50%.
Wow. And symptomatically, the patient experiences reduced friction during intimacy, but the sources show it goes far beyond sexual satisfaction.
Way beyond, because the pelvic floor acts as a physical hammock supporting the bladder and bowels.
So laxity often presents as a constant feeling of heaviness in the pelvis or frequent urinary incontinence. Okay, let's unpack this with an analogy.
I love your analogies. Go for it.
If laxity is like a favorite hair tie that's been stretched out and lost its snap over time, people naturally assume the logical fix is just tightening it back up.
And that logical leap is exactly where the clinical danger lies.
Because they notice the looseness, assume tight is better, and then misinterpret any subsequent feeling of restriction down the line as a positive sign of recovery.
Yes. But the sources are flashing neon warning signs about that exact perception. What a patient might describe as desirable tightness is often severe tissue rigidity.
Wait, really? So feeling too tight isn't a good thing?
Not at all. It can be the formation of dense scar tissue, making the vaginal canal painfully narrow, or a total loss of natural mucosal moisture.
So it's not the healthy snap of an elastic band, it's a physical, painful restriction.
Exactly. And that physical restriction is the defining characteristic of vaginal stenosis. Medically, we're talking about a literal narrowing and shortening of the vaginal vault.
So the actual anatomy changes.
Yes. A healthy vagina has these natural accordion-like folds in the tissue called rugae, allowing it to stretch and accommodate. In stenosis, those rugae are obliterated.
Obliterated, that is a strong word.
The tissue becomes pale, dry, rigid, and fragile. It actually loses its blood supply, becoming prone to tiny, painful bleeds known as petechiae.
And what's causing this obliteration? The literature heavily points to trauma, most notably radiation therapy for pelvic cancers.
Right. Cervical, endometrial, vaginal, anal, and lower rectal cancers. The literature breaks down the timeline of that damage beautifully.
Through the acute phase of radiation, the tissue suffers severe inflammation and ulceration as the energy kills the cancer cells.
But the permanent structural change happens in the chronic phase.
That's the ischemia, right?
Yes, the local blood vessels are damaged, leading to ischemia, which is a permanent reduction in blood supply. Without good blood flow, the tissue basically starves and begins to atrophy.
And then the body attempts to heal this massive injury by laying down collagen, but the process goes completely into overdrive.
It overproduces disorganized collagen, creating what we call circumferential fibrosis.
Circumferential fibrosis, so dense rings of scar tissue.
Hence, unyielding rings. In severe cases, it causes adhesions where the walls of the vagina literally fuse together.
Oh, wow. And it's not just radiation, right? We also see stenosis following pelvic surgeries or triggered by sudden severe estrogen loss, like a bilateral oophorectomy.
Exactly.
So going back to the hair tie analogy, stenosis isn't a healthy, snappy hair tie. It's a rubber band that has been left sitting on the dashboard of a hot car for 3 years.
That is a perfect description. It is baked, dried out, and brittle.
If you try to stretch it, it doesn't yield. It just causes immense pain or it snaps.
And the clinical implications of that brittleness are severe because routine pelvic exams are mandatory for cancer survivors to check for cellular recurrence.
Right, they have to be monitored.
But stenosis makes inserting a speculum agonizing and sometimes physically impossible. For the patient, any attempt at penetration feels like hitting a brick wall.
And the hidden numbers here are just shocking. The reported incidence rates of vaginal stenosis after pelvic radiation in these studies vary wildly.
Wildly, from 1.2% all the way up to 88%.
An 87-point variance in medical data. That points to a massive failure in tracking, doesn't it?
It absolutely does. The sources indicate this relies heavily on retrospective evidence, small study cohorts, and this is key zero standardized grading systems across oncology.
And it really highlights a profound psychological toll and stigma. Women surviving pelvic cancer are frequently hesitant to discuss their vaginal health.
Because the prevailing internal narrative is often, well, I survived a deadly disease, I shouldn't complain about sexual dysfunction.
And clinicians, in turn, routinely fail to proactively ask about it during follow-ups.
Right. But when researchers conduct prospective studies specifically looking for stenosis, the incidence rates immediately surge toward that 88% mark.
Unbelievable. So to really answer your core question, can stenosis be mistaken for tightness? We have to tease apart some overlapping conditions.
Yes, because a patient reporting painful tightness could be experiencing a few different distinct physiological processes.
Genitourinary syndrome of menopause, or GSM, is a major one in the sources.
Yes. GSM replaced the older term vulvovaginal atrophy to better capture the systemic nature of the syndrome. It is fundamentally driven by estrogen depletion.
Because estrogen acts as the crucial fuel maintaining the thickness, elasticity, and overall health of the vaginal tissue.
Exactly. When estrogen levels plummet, whether from natural menopause, systemic chemotherapy, or ovarian failure, the superficial epithelial cells lining the vagina are lost.
And that cellular loss triggers this fascinating cascade in the local microbiome. Those superficial cells normally release glycogen, right?
Yes, and glycogen is the primary food source for lactobacilli, the healthy bacteria that keep the vaginal environment acidic.
So without glycogen, the lactobacilli starves and the vaginal pH spikes above its normal acidic state.
And that elevated pH makes the tissue incredibly dry, thin, and highly susceptible to micro tears and chronic infections.
So GSM frequently mimics stenosis because the tissue feels tight and intercourse becomes incredibly painful.
Exactly. And unmanaged severe GSM can actually create an environment that fosters mild stenosis over time.
Okay, but what about vaginismus? Because if a patient is experiencing this painful tightness, a quick internet search might lead them to self-diagnose with vaginismus.
Which happens all the time. But we have to make a clear distinction here between a hardware issue and a software issue.
Oh, I like that. So is vaginismus a hardware issue or a software issue compared to stenosis?
What's fascinating here is that vaginismus acts as a software issue. It is an involuntary muscle spasm, a panic response of the levator ani and surrounding pelvic floor muscles.
But the physical hardware, the mucosal tissue, the elasticity, the cellular structure, is entirely healthy.
Completely healthy. The brain is just sending a defensive signal commanding those muscles to clench, often linked to anxiety, the anticipation of pain, or unresolved trauma.
The muscles act as gatekeepers.
Exactly. But stenosis and GSM are pure hardware issues. The actual tissue has undergone a physical, structural metamorphosis. It has scarred, shortened, or completely atrophied.
So the pelvic muscles might be totally relaxed, But the physical space to accommodate expansion simply no longer exists.
Right, the hardware has changed.
And that distinction between hardware and software becomes absolutely critical when a patient seeks treatment.
Because misdiagnosing the hardware issue of stenosis as the software issue of vaginismus leads to entirely ineffective therapies.
And even worse, misinterpreting structural scarring as a simple desire for more tightness leads patients directly into the internet's most predatory marketing trap.
Oh, vaginal rejuvenation.
Yes, the internet is flooded with these vaginal tightening lasers, radiofrequency treatments, and proprietary creams marketed to women who feel they are too loose.
Clinics heavily market these energy-based devices, and they operate by delivering highly controlled thermal injury to the vaginal mucosa.
The mechanism is basic wound healing.
Exactly. The microinjuries trigger the body's natural inflammatory response, specifically stimulating fibroblasts to produce new collagen and firm up the vaginal wall.
And for a patient with mild laxity from childbirth, creating new collagen provides some structural benefit. But what happens if someone with a hypertonic, too tight pelvic floor or early stenosis undergoes these tightening procedures?
It is a recipe for catastrophe. We are looking at tissue already severely compromised by dense fibrosis, a lack of blood flow, and a total loss of elasticity.
So subjecting ischemic, scarred tissue to thermal injury designed to provoke more collagen and more tightening.
Actively accelerates the disease process. The clinical guidelines from NICE, the National Institute for Health and Care Excellence in the UK, include a review of case studies that are genuinely alarming.
The adverse events from transvaginal laser therapy.
Yes. Women with pre-existing undiagnosed structural pain underwent these laser treatments. They experienced severe compounding dyspareunia, which is painful sex.
The sources mentioned one patient suffered significant vaginal lacerations just from attempting intercourse weeks after the procedure.
Because the laser had rendered the tissue entirely rigid and fragile. Treating a structurally compromised vagina with a device engineered to induce tightening is adding literal heat to a fire.
The NICE overview highlighted another case that really stuck with me. A patient underwent 3 courses of laser treatment, and subsequent examination revealed the device had generated a crescent-shaped fibrous band mid-vagina,
A literal stricture. It created a partial artificial obstruction of the vaginal canal.
which underscores why a meticulous clinical examination is non-negotiable.
Absolutely. A clinician must determine if the tightness is muscle spasm, hormonal atrophy, or physical scarring before any energy-based device is even considered.
Okay, so since lasers and rejuvenation marketing are counterproductive and frankly dangerous for stenosis and GSM, how do you actually treat the hardware issue?
Well, the medical literature points to specific, evidence-based hardware solutions. The gold standard for treating the physical narrowing of stenosis is vaginal dilator therapy.
Sometimes referred to as vaginal trainers, which can sound really intimidating.
It can, but the mechanics are crucial. These are smooth, graduated cylinders made from medical-grade silicone or plastic.
And the patient begins with the smallest comfortable size, uses a significant amount of water-based lubricant, and gently inserts the dilator.
Current oncology guidelines recommend consistent use, generally 3 times a week for 5 to 10 minutes per session.
And how exactly does that fix the scarring?
It relies on mechanical tissue expansion. Applying sustained, gentle stretch to healing or healthy tissue actually stimulates cellular division.
Mitosis.
Right. It forces the epithelial cells to replicate and physically breaks down early, fine adhesions before they can mature into dense, unyielding scar tissue.
It trains the biological structure to accommodate volume again.
But mechanical stretching is only half the equation. The newly dividing cells require fuel to rebuild the mucosa.
Which brings us to local hormonal support. For patients with GSM, or those recovering from stenosis, local hormone therapy is required building material.
And the sources emphasize the stark distinction between systemic hormone replacement therapy, which circulates through the entire body via a pill or patch, and local hormone therapy.
Because local treatments are applied directly to the vaginal tissue with minimal systemic absorption.
Exactly. The options include creams like estriol applied with a dosed applicator, waxy pessaries like Imvagis or Vagifem that melt to deliver the hormone locally,
And silicone rings like estring that reside in the vaginal vault, releasing a steady microdose of estradiol for 90 days.
Finding the specific delivery vehicle a patient will actually tolerate and use consistently is the primary clinical challenge here.
But because the systemic absorption is so negligible, local therapies are widely considered safe for many breast cancer survivors, though obviously that's always managed alongside an oncologist.
Right.
There's also a fascinating alternative in the literature: Intrarosa. It does not contain estrogen.
Yes, the active ingredient is a plant-derived hormone called prasterone, essentially DHEA. The biomechanics of Interosa are incredible.
How does it work?
Once inserted, the local vaginal cells absorb the DHEA and biologically convert it into both estrogen and testosterone directly within the tissue.
Wow. So the body does the conversion locally.
Yes, it provides the exact localized hormonal building blocks required to thicken the mucosa, improve natural lubrication, and drastically lower the risk of recurrent urinary tract infections without altering systemic hormone levels.
That localized intracellular conversion completely bypasses many of the concerns associated with direct estrogen application.
It's brilliant. But, addressing the hardware with dilators and localized hormones inevitably brings us back to the software.
Right, because the brain and the body are in constant communication.
A patient dealing with the intense hardware pain of stenosis or GSM is almost guaranteed to trigger the software defense of vaginismus.
The brain anticipates the pain and commands the pelvic floor muscles to violently clench, making dilator therapy impossible.
Which is why integrating a pelvic floor physical therapist is essential here. Treating these conditions requires holistic care.
A specialized PT works to untangle that reflexive loop. They guide the patient through diaphragmatic breathing and specific neuromuscular relaxation techniques.
They restore the patient's voluntary control over the levator ani, allowing the muscles to remain passive while the dilator does the mechanical work on the tissue.
It's all connected.
Ugh.
So synthesizing all of this for you, the cultural narrative pushes the idea that a tight vagina is the ultimate goal, and laxity is a flaw to be corrected.
But medically, vaginal laxity is a straightforward loss of structural tone, frequently a mechanical result of childbirth.
And extreme tightness, however, is routinely a mask for vaginal stenosis, a severe physical scarring, narrowing, and shortening of the tissue driven by cancer radiation or profound estrogen loss.
Understanding the difference between muscle spasms, which is vaginismus, tissue atrophy like GSM, and scarring, which is stenosis, is absolutely vital.
It's vital to avoiding the wrong treatments and finding true relief. Approaching structural stenosis with cosmetic tightening lasers is not just a misguided treatment. It actively accelerates the scarring and inflicts permanent structural damage.
It's so dangerous.
But having this information equips you. Knowing this doesn't just make you well-informed. It equips you to advocate for yourself or a loved one. When you step into a medical setting where symptoms of painful tightness are casually dismissed as normal aging, or just the unavoidable tax of surviving cancer, you now have the exact vocabulary to push back.
Exactly. You can ask your clinician to differentiate between a muscular spasm, GSM, or structural stenosis, and demand the proper local therapy or a pelvic PT referral.
Before we wrap up, I want to toss it over for a final thought. What should we really take away from this massive data gap we discussed?
Consider the sheer number of cancer survivors worldwide who undergo pelvic radiation every single year. Millions. If up to 88% of them experience some form of vaginal stenosis, yet it remains shrouded in taboo and poorly documented. How much of our global post-cancer care is completely ignoring a massive fundamental aspect of human recovery and intimacy simply because we are too embarrassed to talk about it?
That is definitely something to ponder. Thank you for joining us on this deep dive.